Good morning. I'd like to thank SAGES for the opportunity to present our paper today entitled, Does the Robot Make a Difference? Oncologic Resection in Laparoscopic versus Robotic-Assisted Transhiatal Esophagectomy. The authors have no conflicts of interest or financial ties to disclose. The transition from open to laparoscopic transhiatal esophagectomy is fairly well documented in the literature. The benefits include shorter hospital length of stay, decreased postoperative morbidity, and all the while maintaining similar oncologic outcomes from open procedures. And in a similar surge, robotic surgery is increasing in volume. Robotic case volumes tripled over the last 4 years, and scholarly articles have doubled over the same time period. Esophageal surgery is an ideal area of robotic expansion. Similar to the pelvis for colonic and urologic surgery, the robot offers unique advantages and unique characteristics that are well suited to that area. The advantages of robotic surgery include improved visualization, tremor stabilization, wristed instruments, and surgeon ergonomics. The disadvantages include increased operative time, increased cost, and specialized training, and an increase in the learning curve. There's been multiple papers examining transthoracic esophagectomy robotic data, but there's little data that exists regarding robotic transhiatal esophagectomy. No single institution direct comparisons between laparoscopic and robotic techniques currently exist. And so our purpose was to examine and compare short-term oncologic outcomes of patients undergoing laparoscopic and robotic-assisted transhiatal esophagectomies at our single institution. We looked at our patients in a retrospective database, and we found 36 patients who underwent consecutive laparoscopic and robotic-assisted transhiatal esophagectomies over a 3-year period. There was 18 patients in each group, in the laparoscopic and robotic group. We excluded all patients with benign disease or any patient who had a planned open procedure. All procedures were performed by a single foregut and thoracic surgeon, and the operative procedure included division of the short and left gastric vessels, transhiatal esophageal mobilization, creation of a gastric conduit, a pyloroplasty, a feeding jejunostomy tube, and a cervical esophagogastrostomy, which included a hybrid stapled and a hand-sewn anastomosis. All of the patients were placed in the ICU postoperatively, and a routine esophagram was performed in all of our patients on postoperative day number 5. Our postoperative complications were categorized according to the Clavian-Diendo classification. And so look at our patients and their demographics. They were all around 60 years of age. There was a predominance of males in our group. They all had about the same BMI, and all procedures were performed for malignancy. Our mean operative time was just under 3 hours at 164 and 168 minutes apiece, which was not significant. There was only one anastomotic leak in each group. Our major complications, which we included anything that was a CD grade over 3 or greater, was 3 in our laparoscopic group and 2 in our robotic group. Our pulmonary complications were minimal in each group, and we had 1 early reoperation for bleeding in our laparoscopic group. And in a similar vein, we had 1 mortality in our laparoscopic group, and this was on a known cirrhotic who developed fulminant hepatic failure afterwards. Our hospital length of stay was around 10 days for each group. Our ICU length of stay was a little bit greater in our laparoscopic group, but it didn't reach significance, and this was because of our 1 patient, our 1 mortality. And in some recent data that we've received from the hospital, our direct cost per case was actually lower in our robotic group. The patients who underwent the esophagectomies were mainly for adenocarcinoma, with 1 more in our laparoscopic group, and a greater number of squamous cell carcinomas in our robotic group, but this didn't reach significance. There was 2 neuroendocrine tumors in our laparoscopic group, and all of our patients in the robotic group underwent neoadjuvant chemoradiation, while only 83% in our laparoscopic group did. Our average lymph node yield for each group was about the same, at around 14 lymph nodes per case. It was slightly higher in the robotic group, but this was not significant. Our patients with positive nodes was similar in each group, with about 1/3 of our patients having found positive nodes at the time of surgery. And in our patients with positive nodes, the number of positive nodes retrieved was a little bit more in our robotic group, but this didn't reach significance. All of our patients had gross negative margins at the time of surgery, and our R1 resection was 94% in each group, with 1 in each group having microscopic positive margins. About a quarter of our patients were upstaged on pathology, while half of our patients were downstaged on pathology. And about 20% of each group underwent a complete pathological response. And so, from our data, we can see that laparoscopic and robotic-assisted transhiatal esophagectomy yields similar perioperative oncologic results, including lymph node yield and margin status, all while with no increase in our operative time with our complications or our cost. And so our next steps is we need to look at our long-term survival data, and we need to improve our non-thoracic oncologic outcomes, including lymph node yield, to match those of thoracic surgery, the thoracic approach, while maintaining the minimal morbidity and mortality of the transhiatal approach. And in general, define the role of robotic esophageal surgery. And so in our experience, robotic transhiatal esophagectomy can be considered non-inferior oncologically when compared to laparoscopy. And with that, I want to thank you for the privilege to present this and open the floor for any questions.